Clinical examination. Polycystic kidneys. General features. Is there any evidence of renal failure or renal replacement therapy? Look in the root of the neck and below the clavicles for tunneled dialysis catheters, or scars indicating that these may have been inserted in the past. They typically enter the internal jugular vein low down in the neck and exit the skin 3/8 cm below the clavicle in the midclavicular line. Look for arteriovenous fistulae in the arms to indicate treatment with hemodialysis, or scars over the forearms and in the elbows that might be due to attempts to create such fistulae. Has the patient had neck surgery, perhaps a parathyroidectomy? Abdominal examination. The instructions state that the abdomen will be swollen. Is this symmetrical? Does it look like fluid, suggesting ascites and, most probably, a hepatological case? Is there a Tinkoff catheter in situ, indicating peritoneal dialysis treatment? Look carefully for scars. These may be from previous Tinkoff catheters, which are inserted in the midline about 5 cm below the umbilicus and tunneled to exit laterally, or may be related to renal transplant operations, which leave a hockey stick incision in either the right or left iliac fossa. The most likely finding is bilateral abdominal masses, in which case it is essential to have a logica technique for distinguishing between bilateral polycystic kidneys and hepatosplenomegaly. Remember the 5 clinical features that can be used to do this. 1. Can you get above the masses? If yes, this indicates that they are renal. You cannot get above a liver or spleen. 2. How do the masses move on respiration? A kidney moves up and down, a spleen moves down and across, towards the right iliac fossa. 3. Are the masses palatable? A kidney, being a retroperitoneal structure, will move forwards when pushed forward by fingers pressing firmly in the renal angle, but a liver or spleen will not be affected. 4. Percussion note: kidneys are resonant, usually, but the liver and spleen are dull, always. 5. Can you feel a notch? This is a feature of some spleens. Remember that polycystic enlargement of the liver is a common finding in polycystic kidney disease, so do not be concerned if you can feel what you think is a kidney on the left side and what you think is a liver on the right. You are probably correct. If you cannot feel both kidney, also look for the scar of nephrectomy. In polycystic kidney may be removed due to symptoms or to create space for future transplantation. Also examine the patient for inguinal hernias, or evidence of previous repair, since these are associated with polycystic kidney disease. If asked whether you would like to extend your examination of the patient, say that you would want to check BP and perform fundoscopy looking for signs of end-organ hypertensive damage. NB. Polycystic kidneys range in size from barely larger than normal kidneys to being so large that they distend the abdomen. In the latter case they can be confused with acidic distension and may be hard to feel as distinct masses. Remember that patients with polycystic kidneys, particularly women, can have a very large polycystic liver. Transplant kidney. General features. Look for evidence of the following: an underlying condition causing renal failure, treatment or complications of diabetes, hearing impairment, Alport's syndrome, facial rash, systemic lupus erythematosus, or collapsed nasal bridge, antineutrophil cytoplasmic antibody-associated vasculitis. Previous renal replacement therapy, arteriovenous fistula, hemodialysis, or an abdominal scar, continuous ambulatory peritoneal dialysis catheter. Complications of long-standing renal impairment, parathyroidectomy scar and carpal tunnel release, dialysis-related amyloid. Numerous features are commonly found in the general examination of transplant recipients, many of which are the direct consequence of immunosuppressive drugs. Steroids, moon face, buffalo hump, central obesity, acne, bruising, thin skin and striae. Cyclosporin, gingival hyperplasia and hirsutism. Sirolimus, rapamycin mouth ulcers and acneiform rash. Long-standing immunosuppression, field change in skin of sun-exposed areas, typically face and backs of hands, warts, actinic keratosis, and scars from removal of squamous/basal cell carcinomas. Abdominal examination. The typical sign is a scar in the right or left iliac fossa beneath which there is a palpable smooth mass, which may feel very superficial or may be quite deep. This is the transplanted kidney. Look carefully at the other iliac fossa for another transplant, which may be small and shrunken, a previous failed graft. Palpate carefully for polycystic kidneys. Further discussion. What are the common causes of renal failure? Diabetes mellitus is the commonest cause of end-stage renal failure in the UK, 20 to 30% and increasing. Biopsy-proven glomerulonephritis, 15%, with IgA disease the single commonest form. Congenital dysplasia or reflux nephropathy/chronic pyelonephritis, 10 to 15%. Autosomal dominant polycystic kidney disease, 5%. Obstruction, 5%. Renovascular, 5%. Multisystem autoimmune/vasculitis, 5%. Cause unknown, 20 to 30%.